Okay, let's go ahead and get started. We've got folks that are trickling in. We'll let them come in over the next minute, but it's 6:02. So for the sake of time, we'll get started. Hello, everyone. Welcome to our Ask the Doctor session tonight. My name is Shelly Korean with SkyPass Foundation. Good to see everyone. I hope everyone is doing well and staying safe. Thank you for taking the time to join us today. We missed some of you last month as we took a quick break from these monthly sessions, but we are back tonight with a very special guest, Dr. Michael Oaken. Now, if I were to do a full introduction on Dr. Oaken, it would probably take up the whole hour as he's extremely accomplished and has a long list of credentials, as I'm sure all of you know. So for the sake of brevity, I will give a high-level overview introduction for those of you who are not familiar with Dr. Oaken and his work. He is currently the chair of neurology and the professor and executive director of the Norman Fixel Institute for Neurological Diseases at the University of Florida. He has also served as the National Medical Director for the Parkinson's Foundation since 2006, and he recently authored a book called Living with Parkinson's that we will actually be talking about today. We had actually sent the link to that book in our email promotion, so hopefully some of you have had a chance to check that out already. Dr. Oaken, it is an honor to have you with us here today. Thank you for taking the time to be here, and we're excited to hear from you. Also joining us today is Dr. Shilpa Chitnis, who is no stranger to most of you. Dr. Chitnis is a professor of neurology and movement disorder specialist at UT Southwestern, and she sits on our board here at SkyPass Foundation and is a huge part of everything that we do for the Parkinson's community, and she will be moderating our discussion today. So today's topic is a very popular one that was very highly requested, and that is deep brain stimulation for Parkinson's. As I mentioned earlier, we will also be talking about some other topics from Dr. Oaken's book, with DBS being our main focus. We got tons of questions from you guys on this topic, so we've compiled that into a list, and we'll be addressing those one by one. This is not going to be a presentation or a lecture. We want this to be interactive, so please feel free to ask us your questions throughout the conversation. There should be a chat button on the bottom of your screen that you can utilize to interact with us for any questions or comments that come up. You can also use the raise hand feature if you wish, and we'll get to you as quickly as we can. So Dr. Chitnis, I will now hand it over to you.
Thank you, Shelley, for the kind introduction, and thanks, of course, to Dr. Oaken for being here. For everybody out there, I have to say that Dr. Oaken is younger than I am, but he has served very effectively as not just a friend, but a very good mentor for me. And I have to say, at least part of why I'm here and what I'm doing, I really, attribute it to the great mentorship and support that I got from Dr. Oaken. So really a big shout out. And there are hundreds or maybe even 1,000 people like me who he has mentored. So really an honor to be here with him. So, Dr. Oaken, if I can ask you, a question as to what was your, there is a lot of self-help Parkinson's books out there. And what was your motivation behind putting together this book? And obviously anything that comes from, from the house of Michael Oaken is not going to be just yet another book. So what was your motivation for doing this?
Well, first, thank you, Shilpa, and thank you for the SkyPass Foundation and your board for the, really tremendous invitation, and it's an honor to be here. And I appreciate the opportunity to speak to your group, and hope everybody's doing okay with the current crisis and coping well and learning how to live as best I can. The book was kind of interesting, and I would say that, I've been involved with a number of different projects over the course of my career, and, good bit of research, a lot of research papers, and a lot of, helping people do theses and all the things that academics do. And before I was in medical school, and when I was in medical school, I did a lot of writing, short story, poetry, things like that. So I never endeavored or saw myself as a researcher. So maybe it's a bit of a return back to, some of my early identity. And the other thing is, a number of years ago, we put together a book called 10 Secrets to a Happier Life. And it was a little bit of an accidental book, but it was kind of about those things that are simple things that you can do that can change your life. And more people read that book by a log factor than any of the papers that I've written in research. And we've written quite a number in our group over the years. And that was a good lesson to me to just, try to gauge what kind of impact we can have on the community. And so I think these types of projects where we can try to speak in very understandable terms and draw analogies and help people to understand not only the disease itself, but that there are people behind each disease, and that there are lots of things that people can do to lead a better life. And so this book is kind of, I would say, number 3 in that series of books for a better life. There were 10 secrets to a happier life, and then people said, well, you got to tell us about what's new and what's the research. So we wrote a book about the 10 breakthroughs. And then this book is really a return to more of an opportunity to talk about all the tips. And so Irene Malati, who's just a tremendous human being and one of our great professors at the University of Florida, and Wissam Deeb, who was at UF and has just taken a job at the University of Massachusetts to lead up one of their movement units. We wrote this together, and it has all of our tips, and we partnered up with a publisher called Robert Rose in Canada. And we chose Robert Rose because they're a famous publisher of cookbooks. And so if you look at this book, there's a lot of charts, there's a lot of almost like recipes and a lot of pearls and a lot of things that you can do to try to help, with actually living with the disease, because we believe that you can lead a happy life with Parkinson. And so the name of the book is Living with Parkinson's.
Thank you. That's a lot of work that goes into this. One of the questions I want to ask you, Dr. Oaken, is, even personally myself, as a movement disorder neurologist, when you see a patient for the first time, really, a lot of times, if they don't have a tremor, then the patient basically says, oh, I couldn't have, they don't go to a neurologist because they think that if I don't have a tremor, then I don't have Parkinson's disease, and then when they come in shaking, they're hoping maybe that they have like a central tremor, So I always find it so hard to tell a patient about a new diagnosis. What is your approach in, what kind of strategies you use to tell a patient about the new diagnosis of Parkinson's disease, which, as much as, we can do so much better for people with Parkinson's now, but they still feel, devastated to have this new diagnosis. So what are your strategies for that?
So tens of thousands of people are going to receive a diagnosis of Parkinson's disease in this calendar year. It's the most rapidly growing neurological disease, period. Any disease, stroke, Alzheimer's, it's growing more rapidly. And if its expansion continues at the current rate, the numbers are staggering and could bankrupt Medicare and really affect society in ways in which I think we can't imagine. And when you really sort of hammer down and focus and think about those 4 words, you have Parkinson's disease, they can be devastating to people when they get that diagnosis. And so one of the tragedies of healthcare is that we don't have enough people who are educated, whether it's general doctors or neurologists. And certainly there's only about 40 or 50 Parkinson specialists trained per year in the United States, which is, if I may use an adjective, pathetic, in what we face. And so if people don't understand the disease and they're giving out the diagnosis, they're going to potentially leave the impression that they've been diagnosed with something that they don't have. And so most families will immediately equate a diagnosis of Parkinson's disease to being similar to, if not the same as, a diagnosis of, let's say, Alzheimer's disease being the most common, or ALS. And we've asked patients about this. And so getting the diagnosis right is the first and most important step. And we have to really teach the general practitioners. We have to teach, general neurologists even, not only to get the diagnosis right, but to frame it properly, because we have patients with Parkinson, as you know, and we say persons now, we don't say patients anymore. We have persons with Parkinson who live 20, 30, 40 years good lives, depending on your subtype. And so it's really irresponsible to give the diagnosis in anything less than a complete picture for patients or for persons and for family members, so that they can have this opportunity to lead a meaningful life. And one of the things we talk about in the book is when you live with Parkinson disease, we have met so many people that actually say their lives are better since getting diagnosed with Parkinson. It's opened their eyes and changed the way that they live their lives. And so we approach this, very, very differently, and we need to do a better job, I think, as a society in delivering the diagnosis. It's a very important moment in not only that individual's life, but in a whole family unit and extended unit's life.
Absolutely. And can you tell us about the content, the chapters? What all does your book cover? What aspects?
Yeah, so the book is called Living with Parkinson's Disease, and it's a complete guide for both patients and caregivers. And we start off with lots of tips and pearls. And remember, it's by a publisher that did a lot of cookbooks, and so they've worked with us on making the format really nice and having a lot of place where we can share our pearls. And you and I have written a book together, so I love the pearls. I love to end with pearls. And then we also have a chapter at the end that has, a composite of all of those pearls. But the book talks about, really starts from that, the point of getting the diagnosis right. When do you start medications? But then gets right into the tips and things that you really need to know and need to be armed with in terms of exercise, rehabilitation therapies, and other therapies. We talk about all the interdisciplinary aspects of care for the disease. We get into the specifics of treatment of motor and these so-called non-motor and neuropsychiatric features, and really drill in with some good practical tips, but also some of the details that you need for formulas to treat things like constipation or dizziness when you stand up, and some of the tricks and if you will, that we have learned over the years. We have a whole chapter on nutrition, and I think you're going to see an explosion of really good nutrition and microbiome and all the things that are living in your gut. You're going to see this gut-brain area of research explode over the next several years. So we talk a good bit about that, some of the newer therapies and how to employ them, and really try to bring it together, but very practical tips. And one thing we learned that was really just insightful and humbling when we put the 10 Secrets book together, we didn't expect that like a lot of people were going to read it. I work for the Parkinson's Foundation as their medical director since 2006. And so we expected these were like things that everybody knew and everybody was doing, and we were just kind of summarizing it. And it was kind of a runaway bestseller of a book. And we realized it's not that, it's not always what you assume. And so we have to go into our discussions with families and our discussions with persons with Parkinson with the idea that let's make sure we share all the practical knowledge that we have, and we do it in a way where it can come across and be easily accessible. Because as you know, Shilpa, there's everybody's got a shelf in their house with self-help books that are full of dust and don't get pulled off the shelf. And so we really wanted to produce another book because we felt like the last two books were not dusty books that really helped people. So we really wanted to produce something that would give a lot of good practical tips.
Absolutely. And then just one last question I want to ask about the book. One of the things that I fear with patients is they want me to tell them what's my lifespan, what's my, how am I going to look in 10 years, 20 years? Do you worry that when we teach them about about the disease in detail, does that add a level of anxiety to a patient? Because now they are reading about all the possible things that, especially if it's a person that was just diagnosed. And is that something that you worry about?
Yeah, I think that that it's really it's really important that that we're clear and and concise, but that it's a balance, right? And so when you take the Hippocratic Oath, it's a balance of taking care of people and learning to care for them, and expressing the hope and the optimism that you have, but not being too Pollyanna-ish. But at the same time, we have the advantage. The very few of us that have training in Parkinson, and there's only 40 or 50 that get trained per year. We have the advantage of having seen tremendous numbers of people that have the disease and have done well for many years with a good strategy. And so helping people to understand what kind of Parkinson they have, and so there are different subtypes, and that we're going to take the journey together, and that it's journey, and we're going to get on the road. And as Lu Zhan, the famous Chinese philosopher, once said, there were no roads, and there are only roads when people begin to walk on them. So you have to walk on that road with the patients, and just let them know you're going to walk the road, and you're going to be honest. But there's a lot of hope, a lot of optimism, and a lot of patients that we treated that have done really well with the disease. And so I think going into it negatively is not really a great way to go into it, but going into it, with without the the sense, the giving people the whole picture, and then letting people know that you're going to watch them, and that, as Davis Finney says, you're going to make every day your best day. And so I think that those are some of the keys. But I do think, after doing this for a number of years, that people have learned how to have faith and to plant those seeds of faith, and that most people, when given the opportunity and given the information, and knowing that there's it really could be a livable disease with a good strategy, would like to go down that road and spend as many years, and we've seen patients spend years, if not decades, of meaningful life with their their family members, and succumb to other things, that we should give them that opportunity. And I think, back to your first question, the way in which we're delivering the diagnosis and framing this is just it's not the most accurate assessment of the situation.
Thank you. And if I may add one last comment, while we're talking about the book, is I think, just like you said, I share exactly your viewpoint, because we come from a similar thought process. But I think educating patients also prepares them so that they could prevent some of the things, like dysphagia, aspiration pneumonia. Like, these things are, relatively preventable, like falls, bowel obstruction, managing constipation. So, my personal view, just like yours, is having the introduction to the big picture, and the tips should not be taken or construed as this is going to be my life and have a negative view of it, but to say, if I were to do this, and this, that I could possibly live a much better life than I would have lived otherwise. So I think, thank you so much to you and Irene, who's also a personal good friend, for taking this effort. I know you're very busy to put together this book, and then to the patients, I really hope you read it, and I'll be writing a personal review on this shortly. And what we will do now is, Shelley, actually, if people have any questions about the book, maybe we can just entertain them at this time, and then we can go on to talking about deep brain stimulation. So if you want to just open it up I'm just going to give people 5 minutes if they have any questions to Dr. Oaken about the book.
Sure. One question that actually came in while Dr. Oaken was speaking is, to what do you attribute the relatively rapid rise in the diagnosis?
Yeah, that's a great question. So at the beginning of COVID, another one of our books got held up in the the morass of everything that's going on with the pandemic and factories closing. But is out, and it's called Ending Parkinson's Disease. And I was very fortunate to write this with 3 other really terrific co-authors, including Ray Dorsey at the University of Rochester. And Ray is an expert at health policy, health economics, and impact. And so he's been studying, how Parkinson is behaving, like, for example, between 1990 and 2005, or 2015, there's sort of a, looking at 25-year epochs and seeing it more than doubling twice and looking all the way out to 2035. And so when you drill into the statistics, most people thought on the surface, and as we were researching the book, I think a lot of us thought on the surface that age was going to be the only factor that was driving this rapid increase in Parkinson. So in other words, the greatest advance in the last 100 years has been doubling of the lifespan. It's not your computer, it's not your iPhone, it's that people live twice as long. That's a pretty big advance. And when we look at things, we think, well, you live a lot longer, your brain wasn't designed to live that long, so now you're getting Parkinson. It makes a lot of sense. The cells are starting to give out and they're starting to die off. Well, it turns out when you control for that in a scientific way, it doesn't account for this rapid expansion. And so it's important to keep in mind that there are other factors such as pesticides, the environment, and other things that are probably driving these changes. And so I know I'm here to talk about deep brain stimulation. And Kay just wrote a question in. She's here to hear about DBS. So let's talk some DBS, Dr. Chitnis. What do you want to know?
Okay, so maybe you can basically tell people a little bit about how DBS came about, like just a very short synopsis of development of DBS.
Yeah, so historically we have actually, believe it or not, made lesions or cut pathways in the brain all the way through the 1900s. And there was a famous guy by the name of Busey that used to make these cuts in the brain. And when they cut the area that controlled motor function, people got weak, but their tremors stopped, but they got weak too. So that wasn't obviously a great result. But then people began to either burn particular areas of the brain, or they would inject alcohol. There was a famous neurosurgeon named Irving Cooper who was in New York at St. Barnabas Hospital, and he would inject alcohol into the brain, and that would kill the cells around the alcohol, and you could make lesions. And Cooper and others had noticed if you make lesions in certain areas of the brain that it can actually improve the symptoms. And in fact, part of this was because Irving Cooper ligated an artery called the anterior choroidal artery that was giving nutrition, blood or nutrition, to an area of the brain important to Parkinson. And that's called the pallidum or the globus pallidus. Not as important that you remember what that structure is, but fundamentally, as you disrupted that circuitry, even by making lesions, we began to understand that this could change the way different brain regions were talking to each other, change these pathways called the basal ganglia. And with these changes in conversation, that people were getting better with their symptoms. And in the late 1980s, based on some work that one of my mentors did in mapping the basal ganglia, a very, very fine gentleman that won the Lasker Prize named Malin DeLong at Emory University, he was able to map out by injecting viruses into these areas and figuring out where they all connected. And then another surgeon in France who also won the Lasker Award. The Lasker is the award that you get before you get the Nobel. At least 37% of people that get the Lasker get the Nobel. So these are two pretty smart guys. And he had the courage and the aha moment, instead of making a lesion, to not only stimulate in the operating room, but to leave a stimulator in place. This had been tried before by many people, but to leave it chronically and have it work and choose the right targets, it stuck. And it created the single best treatment for Parkinson's since the introduction of dopamine replacement.
Wonderful. So when you think about DBS, so how do you pick what is your algorithm that you pick patients as candidates for DBS? And how do you think about how many years of disease they had, or what are their characteristics?
Yeah, so we learn. So we haven't, obviously we don't have all the answers, but when we were first beginning to do DBS a couple of decades ago, we would choose patients very carefully. And instead of treating it like a gallbladder operation, we would put together a team. We called a multidisciplinary team. And so they would see a neurologist, and we would give them some dopamine and see how they responded to the dopamine, and symptoms that responded to the dopamine seemed to get better when we did the DBS. And so that was sort of an important aha moment. You needed to have some response to dopamine. We learned over time that the motor fluctuations going up and down improved. It could suppress dyskinesia, the dance-like movements from the medications, and it could suppress tremor, even if the tremor didn't respond to our dopamine test. And so that was one aspect, but to keep people safe, we needed to know, was their cognitive function intact, or how impaired was it? So we had neuropsychologists, we had psychiatrists, that we underestimated the value of psychiatry and making sure that people had depression and anxiety under control, because we saw high amounts of suicide early on. People talk about the lessons that we learned early on with heart surgeries. There are lessons that we learned early on with any type of surgery, including this type of brain surgery. And we had them see, occupational therapists and physical therapists and nutritionists and financial counselors. And so over time, what happened was we realized how important this process was. And so we began to evaluate people in a very systematic way. We called it fast track. Why did we call it fast track? It wasn't necessarily because it was fast. It was we should have called it slow track. But the reason we called it fast track was because we actually did something for its time that was reasonably revolutionary, which was we scheduled patients so they could consecutively see all these people over a day or two, so they didn't have to, bounce all around. And so one of our philosophies was the patient's the sun, and we should revolve around the patient. And then we do something else that is revolutionary in the healthcare system, and that's that we talk about people behind their backs. And so this is actually the highest level of care that you can hope for, when a group of people that are taking care of you actually talk about you, and then they come back and they talk to you. And we learned over the years that it was important to ask them, what are your expectations? What do you think is going to get better from this operation? And then we could have that dialogue, and this is what we've seen, this is what we've learned, maybe we could go with this, maybe we can go with that target. And so that was, sort of the general approach. And so Debbie Gornbein in your group is asking about how it impacts speech. And so just to tie this in, so we have a speech language pathologist, Debbie, that actually meets with the person as they're going through this. We look and see what they have at baseline before they have the stimulator. And we know now if we put one stimulator in, we get less speech effects than if we put two. So two sides of the brain, more speech effects, meaning worsening than less. If you have Parkinson, if you're being operated for Parkinson, then we know that the globus pallidus and the subthalamic nucleus, and occasionally the thalamus, if you have tremor, are the most common targets that we choose. And we try to choose the targets based on what you want for your benefits. We talk about whether you want a unilateral or a bilateral, so less speech and less walking problems with a unilateral stimulator than when you use two sides. And by the way, when you do two sides for speech with the old-fashioned lesions, that's one of the reasons that Professor Benabid decided to put a stimulator in the brain. He had a lesion on one side, and he knew if he put a lesion on the other side, you're going to have trouble speaking and trouble with cognition and thinking. And so he keyed on that by putting a stimulator in instead of making a lesion and leaving it in chronically. So DBS in most cases makes your voice softer, more with two leads than one. We call that hypophonia. There is a speech effect that is really a cognitive effect, but a lot of people think it's speech, but the most common cognitive effect is getting words out of your mouth. It's actually a frontal lobe issue with the front part of your brain called verbal fluency. So that can be impacted with DBS. And occasionally you can get into other speech issues depending on where the lead is and how the current spreads. So speech isn't one that we say in Parkinson in general. From all of the years of experience, we don't say that speech, Debbie, gets better with DBS. We say you're lucky if you get DBS and you don't have any speech effects. And the Parkinson Alliance early on was doing surveys on this, and 70–80% of people with bilateral STN DBS were complaining of speech issues after the operation. And so it's something to be aware of. It's not something that most people, once they understand, will not want to get the operation because of that. But let's say you're a lawyer, or you're a litigator, or you use your speech a lot. It's something to think about and talk to your team about target approach, one side versus two sides, and understanding that there's a risk that speech, and we say walking, talking, and thinking are three aspects that when we do our multidisciplinary evaluation, if they come up and the patients or the persons with Parkinson's say they really want this better, we need to sit down and have a talk, because those are things that not only don't get better, but in a small number of cases could get a little bit worse. So, so thanks for your question, Debbie.
So Dr. Oaken, thank you. And is everybody with Parkinson's a good candidate for DBS?
So this is a really common question. And recently, Melissa Armstrong and I did a little bit of writing for a journal called JAMA, Journal of the American Medical Association, where we looked at sort of back in February, March, and there's a patient page and a review article on Parkinson. And I don't suggest anybody read the whole article. I actually think it's pretty good, but there's some good pictures in there. Thank you. And it turns out that if you look at that article, there's a window. So there's a window of time. So if you imagine Parkinson as a lifetime disease that you're going to have for many years, there's a window when each type of therapy, whether it's physical therapy or occupational therapy or speech therapy or deep brain stimulation or other rehabilitative therapies, might work better than other areas. And clearly the hot zone for where DBS has had its greatest impact in the field is in sort of that middle zone where you have a lot of fluctuations, where you're going on and off and you're going up and down, and you have responsiveness to the medications and a lot of your motor features. There has been a sense that there is a potential for using DBS early or earlier. And so there was a paper in the New England Journal of Medicine in 2015 called the Early Dbs Study. This studied people who were in their 50s with DBS. They had about 7 years of disease duration. So they weren't actually earlier, but they only were having these motor fluctuations for a year or two. And that's what set that group apart. And they did very well compared to a group of controls that didn't have the operation. And so we know some of the younger patients with motor fluctuations do better a little bit earlier. So you can slide that line a little bit earlier. So does everybody get DBS across the lifetime of the disease? No, but just like every therapy, every drug, every surgery, there's an optimal time for it. And so about 10–15% of people with Parkinson now have it, but over a lifetime for an individual Parkinson patient, a very large number, if not the majority, could benefit from it at some point if they have a medication responsive form of Parkinson. And so it's always something to consider individually for patients. It's one of those questions that doesn't have one right answer. The answer is more, where are you in your disease? What bothers you? Can we treat it with medications or therapies or other approaches? Because remember, surgery is still invasive. We've been involved and done thousands of operations at UF, and UT Southwestern's probably done thousands of operations. You know, we've done a lot. Doesn't mean we need to do more. We need to do the right operation for a patient depending on what their individual symptom is, and can the surgery achieve something that the medicines can't, and is the risk benefit ratio favoring the person with Parkinson, or is it swayed the other way? And that's why these interdisciplinary, multidisciplinary evaluations are so useful, because getting that conversation, getting that dialogue among a group of professionals really helps us to understand an individual, and everybody on that team should be asking the person, what do you want from the surgery? Because I'll tell you, mistakes that we've made early on in the DBS practice is we weren't carefully asking those questions because we knew what was going to get better. We undervalued what the families and the persons with Parkinson wanted to get better. So what was a success to us was a failure to them, which ultimately defines failure.
Understand. I'm going to ask you one last question, Dr. Oaken, and then I'll let Shelley, you know, with the two new, relatively new, Boston Scientific is the latest devices that are there. You know, patients are very smart these days, and, you know, how do you counsel patients about which device, you know, would be best for them?
Yeah, so the field has gotten more complex, right? So we used to have one manufacturer, and that's pretty much how any technology starts when we look at the technology expansion curve, how some new technology comes to be because of some critical need that it's filling within a specific population, and then others will follow. When others follow, it's good because the competition brings more innovation, and it brings out the best in, you know, in various approaches, and then there begins to be a race that can be good for, you know, more rapidly improving a technology that could, you know, potentially provide more benefits to more people. Okay. Now that we have 3 devices that, you know, from 3 different companies that are FDA approved and more potentially coming, it also creates some confusion, frustration, uncertainty among patients or persons with Parkinson and family members. We have individual companies on TV that are, you know, are showing their products, medications, devices, and everybody says, I've got this one. You know, it's kind of like your friend, I've got this bike, so you should have this bike, right? And you say, oh, I need to go get this bike, right? But here we're talking about hardware we're going to put in your brain. So we have a little piece that we put in a journal called JAMA Neurology, and it's called Tips for Choosing a Deep Brain Stimulation Device. And as we go through all of the different tips, many of which we've discussed here, the most important thing that I can emphasize is we have learned a lot of lessons. And the lesson is that the multidisciplinary team, the experienced team, and getting the leads in the right location and the right target is far more important than the hardware that you choose. The hardware is going to work from any of these companies if you get it in the right place, okay? Then once you have decided, you know, whether you should have the operation and how and where and which side of the brain and which target, the last step should be looking at, does the insurance company cover the approach that you want to have? The device may not be labeled for what you need, okay? So it's got to be labeled, because it's a very expensive operation for you to get that hardware. Do you have somebody locally close to you that can handle the device? So for years we did operations on people in countries and in areas that didn't have any access. So we maybe did lesions or had to choose a device from a company where there was support, you know, for that device. And so that's something that's important. And then it comes down to individually what's important to that particular person, and can one or more of the hardware manufacturers, do they have some solution that's available at that time that might enhance and help the outcome for an individual person? But in the end, the one thing I want to stress is all these things are cool, whether they can be used on MRIs, or we can use physiology to guide the programming, whether we can, have access to, leads that will spit the electricity in different orientations and in different directions. It comes down to the needs of the person. And too often than not, I get this question quite a bit. Too often than not, people just want to say, well, which one do you use? And I hear this all the time. And my answer is all of them. I'm for the person with Parkinson. I'm not for a company. I want to understand how it can help. And if that company is going to survive, they want the best product for the right patient too. And so that multidisciplinary process should be what answers that question. You shouldn't be answering that question yourself. It should be the sophistication of the team, and then having a discussion with your group, of open dialogue if you're worried that you're choosing the right hardware. But that's how we approach it. And then one more point on that, just for anybody, I just want to spike the last point here, and that's, remember something. These devices are driven off of batteries that have firmware. So a lot of our fellows that are in training and do research in our laboratory, and PhD researchers that we train, we can change the firmware on your device and make it do all sorts of things that aren't allowed by the FDA now. Okay, so there will be updates on your device, just like there's updates on your iPhone. And each one of these companies, when one of them comes out with an innovation, remember, it's a race now. Just because your thing doesn't have it right now, it might have it, in a few months, and it might be able to be updated if it's not a hardware, and it can be done through software. There's very little evidence now that some of the newer technologies are actually helping things, like speech has come up here. I see in your panelists by turning or steering current in certain areas to improve speech. Some people try to turn off devices. It's not that useful, but every once in a while somebody turns off a device, the speech gets better. So there are strategies you can program with different programs. You can try directional leads, but speech is very hard to improve. And so some of the enhancements we're seeing in the hardware now, people are now set out to prove how this might be useful to try to reduce the number of side effects. So, typically when people have speech side effects from DBS, sometimes it's because the lead's not in the right place, and sometimes the lead's in the right place and it's just spreading current into the wrong pathways or areas. And so I see a few questions on that. Debbie just asked a good question on that. And so it's really tricky and hard to address.
Thank you, Dr. Oaken. That's, if I may say just one last thing to summarize what you said, is essentially, the success of DBS depends on appropriate candidate selection, the wire being inserted in the right spot, and having effective programming for these patients. But having the new devices certainly helps with some creative programming. Somebody wants to know, what are the side effects of DBS, like common side effects and less desirable side effects?
Right. So when we are talking to families and persons with Parkinson, it's really important that we have a frank discussion. There is a really famous quote by Mark Twain, who said, "There are lies, damn lies, and statistics." And so if I tell you, if you're going to an operation and I tell you, okay, if you go to the casino and you pull the slot machine lever, I guess they used to have the pull levers, now I guess they're buttons, but let's pretend there's a lever, because I think that's more fun. So you pull the lever, on the side of the slot machine, you pull the arm of the slot machine, and you're going to win 95 times out of 100. You're going to pull that lever, right? But if you are the one that gets the side effect, if you're in the 5% that maybe gets a little bit of a bleed, a little bit of blood, because remember, we have to pass that electrode through the brain, and there's a lot of blood vessels in the brain. So even if we do imaging where we are trying to avoid those vessels and see where they are, the thing that we fear the most is that we either cause a stroke, or we cause there not to be blood going to an area of the brain, or a little bit of blood leaks out of a blood vessel that we accidentally bump into. We fear that a lot. It happens less than 5% of the time, and meaningfully, it happens only a few percent of the time, where you're going to have, maybe some permanent side effects like weakness or numbness or changes in vision or speech. And if you do enough of these cases, if you do 100 cases, I don't care how good of an expert you are, you're going to have complications. So every expert center has complications. We worry a lot about infections because the device itself, the battery, the wires, everything, it doesn't have a blood supply. So if it gets a speck of dirt on it, think about it. It's not like you can take an antibiotic which goes into your blood and the blood's going to penetrate that metal device, right? And so if it gets infected, it may have to come out. And if we don't get it out soon enough, we may have to take the whole thing out. Hopefully we get it out and we only have to take out the battery and the wire or the connecting wire, which hopefully at some point, by the way, will go away. The connecting wire through the neck could break, so it could fracture. So there could be hardware issues. And so we worry about some of these big things, and we talk about big things with the individuals who receive the therapy. But we also worry about when we turn the device on, it can cause things that are stimulation induced. So it could cause numbness or tingling or pulling or double vision. And hopefully we can either turn it off or turn it to a different setting or put it on a different contact, which is in a different region of the brain, and get away from the side effects. We call that programming. So those are reversible. But then there are effects from just placing the electrode through the brain. And we know from studies now, we did one multi-center study on a device that's now known by Abbott, but it's true of all of the devices that we've studied, that the most common cognitive side effect is getting words out of your mouth, called verbal fluency. And we also know that if you haven't adequately treated depression or anxiety or mood issues, these can get worse. We can precipitate impulse control issues. And so the point is that we see a very large number of potential side effects that can emerge with these therapies. And it's super important to be honest with persons with Parkinson and the families. And we have a free book through the Parkinson Foundation about deep brain stimulation therapy. We just updated it. In fact, they said you need to update the book to Pam Zellman, who's a very gifted advanced nurse provider, ARNP, at the University of Florida. I think one of the best programmers in the country. And Pam is terrific. And so she and I updated the book. Yeah, she's amazing. And we updated the book. And I said, why are we updating the book? We just wrote it. And they said, no, that was like 7 years ago. But anyway, there's an updated version of the book now. Has all the things that you need to think about. And you do need to think about, not only the benefits, but the potential side effects, and put together a profile and weigh the risks and benefits before you have an operation, because it's still brain science.
Thank you. There are a lot of questions coming in, guys. I'm picking, some, and I'll be happy to answer these later by email. Dr. Oaken, do you think speech therapy would help somebody that developed DBS related, stimulation related dysarthria or hypophonia if you're not able to program?
We definitely use it a lot, and it definitely can help in some of the speech. And there's even therapies for some of the swallowing if you develop swallowing issues, which is more rare. But in general, it's good to use, but it's a percentage. I don't think I've ever, used it and had people come all the way back, unless they had a stroke or something like that during the operation, where they get almost complete recovery from that. Generally we see the voice come down, the voice volume comes down. Sometimes we see slurring of the speech, but not always. And so those are definite effects that we see.
Do you think the final results differ between doing awake DBS versus doing a sleep DBS?
Yeah, so I think that, what do I think? We talk about this a lot. We're teaching a course now called the Aspen course that's ongoing this week. And this question comes up quite a bit. And the answer might surprise you. And, I grew up on, doing a lot of physiology in the brain and making sure you have a very complete map. And so, of course, I like doing that. And now we have newer techniques with doing it under MRI, doing it asleep. doing it awake versus doing it asleep. We can use a head frame. There are techniques where you don't have to use a head frame. What gives? And when we look at the results, a lot of the results are very similar. It's hard to compare because these aren't studies with thousands of patients like we see in cancers. You know, it's not just not possible to compare these studies head to head, you know, with the techniques. But we do know in general that as the imaging has gotten better, and the imaging has gotten a log scale better, a lot better. When I first started, we couldn't see the targets. And when you can't see the targets, you know, obviously it's not going to go well, right? You're going to need to have some physiology. You're going to need to listen to those cells, create some maps and figure out where you are. But now that we can see the targets with much finer resolution with the MRI scans and different techniques, we can get closer than we've ever gotten even without the physiology. And so some of these asleep techniques, people have gotten really good at them. It matters less what technique you use as long as you have quality assurance on it. And too many people use a technique and they just assume, you know, oh, I did it, it's good, you know, like, and of course, if you're not looking carefully at your results, if you're not looking where the leads are, if you're not looking at your outcomes, then you'll just assume everything you do is great, right? It's sort of the perfect existence. What you need is a place that's going to have quality assurance. So let's say they do a sleep DBS. Do they have a way to look at where the leads are on all these people and where their outcomes are? You know, that's the key. Do they use a head frame or do they not use a head frame? Do they use microelectrode recording? Do they not use microelectrode recording? If they can get the lead in the right spot, however they do it, if they get good at doing it, then that's a good result for that individual patient. So you want people who are experienced, but who also have a quality assurance program. And so, for example, in our program, over many years, we've developed, you know, a system where after every operation, we do scans, and then we have our fellows in training measure those scans in 3D. We email them to every member of the team, the surgeons, the neurologists, the fellows in training. We all look at them. We look at the programming together, all in a single, you know, file. We look at where the effects were for benefits and side effects. And we all comment. Do we think this lead is slightly forward? Do you think it's slightly back? And that helps us to program it, or it's completely off and we need to go back to the OR. I don't know what happened. It slipped out of place, or, you know, we missed. If we don't have that quality assurance, and this is at a very good program, we're not going to be any good at it. And so I don't think with this type of complex surgery that it matters so much what technique you do, is if your team is really good, they become expert at it, and they're humble, and they're willing to have a quality assurance to make sure that you're getting the benefit that you're supposed to be getting with the individual operation. And so if you're not getting the benefit that you expected, particularly right after the operation, then you need to troubleshoot. And so that's an important aspect of care.
So a question I have, Dr. Oaken, is now that we have other advanced therapies, you have focused ultrasound and you have duopa. Do you counsel patients about them specifically, or are you pre-deciding which patients you're going to talk about DBS, which patients you're going to talk about duopa, or is this something that you give patients an option?
So we give all patients options. So, you know, I like to say I work for the state of Florida, so I'm a government employee. I make a salary, and you know, I want you to do as well as you can, and I want to try to help you as well as you can. So I'm not interested in steering a person to one therapy or another. I want whatever therapy is best for that person. Now it's going to be limited to what you have available at your institution. We do have duopa at our institution. We do have DBS at our institution. We do have a lot of clinical trials at our institution. We don't have a focused ultrasound at our institution, although focused ultrasound is only approved for unilateral lesions. So there's no incision, but you make a lesion from outside the brain with a sound wave into one side of the brain called the thalamus for tremor. That's what it's approved for. And so that's probably a whole different discussion, but there are potentially patients who could benefit from that technology. So we refer patients, you know, that are appropriate to centers who are experienced in that technology.
There's a question from a medical professional that if levodopa does not work for a patient, um, would you consider that patient for DBS?
So it depends. If we do a levodopa challenge and we measure what we think is improving in the patient, or not in the patient, in the person, we want to see the change, and we cannot just gauge the change, the delta, how much improves based on tremor, okay? So sometimes people say, I'm not responding to the dopamine, and more times than not, you'll give them the dopamine and they're responding to other aspects, and they have a dopa resistant tremor, or a tremor 20 or 40% of the time is only partially responsive to medications. That tremor is going to respond well to DBS, and some of the other symptoms that may not be bothersome to that person at that time might be bothersome in the future. If there's no response at all, and you're giving high dosages of per dose of dopamine, so 300 milligrams per dose, so that'd be like 325, 100 Cinemet tablets per dose, you're seeing nothing. You're seeing no dyskinesia. You're seeing, like no change. I worry about other forms of Parkinson, and I worry about whether or not the medication is being absorbed. So I get a study called a gastric emptying study, where we put a little dye in the stomach and we see how long it takes for that dye to get out of the stomach. And it may just be that you have a digestion or gastric emptying issue, that if we solve that, you might absorb the medication. Occasionally, somebody has such violent effects to the dopamine. This is very rare, but we've seen it. 1 in every few hundred patients get such nausea, even when we give a medicine like carbidopa, lodocin, domperidone, motilium, which isn't available in the United States. Then those people could be considered DBS candidates. But we need to convince ourselves that they have regular Parkinson's disease, or alternatively, they have a symptom, even if they don't have regular Parkinson's disease, that we think the risk-benefit ratio is going to be in their favor to do an operation. I think you're muted, Dr. Chitnis.
Where I am is a refrigerator making noise. How common is bradyphrenia or impaired attention in DBS electrode placement? And have you any studies to date shown any potential benefits to cognition among people with PD?
So we have thousands of cognitive studies pre and post-op in our institution. There's a lot in the literature. You very rarely see big positive changes, although sometimes when people are on, when they're on and the medication is working, they pay attention better and they actually do better cognitively. And there are a small subset of Parkinson individuals that I've met over the years, that when they take their medicines, they get smarter on their medicines. But it's not the complete set, and it's not the most common thing. In general, we don't see big improvements in cognition after an operation like deep brain stimulation. We're more likely to see decrements, and the most common decrement is getting words out of the mouth or verbal fluency, which is a frontal lobe issue. You're muted again.
Yeah. So there is I think the FDA just sent out a warning about people with DBS swimming, whether it's in a swimming pool or, anywhere else. Can you comment about that, please?
Yeah, so there was an article in the New York Times and a series of patients from Germany that were having trouble with swimming after the operation. And this wasn't a controlled study, and not all the patients did they turn on and off the stimulation, but there were a few, I think, in that study that they were able to confirm on and off the stimulation. They saw worsening, and actually we have one such patient that we're sure about, and have been mapping the brains and doing something called connectomics, looking at which circuits turn on in that patient when the DBS lead is on and working. And there may be a circuitry that we're accidentally stimulating that is making it difficult to have alternating movements that are required for swimming. And this is in the in the area around where the supramarginal angular gyrus are, that are sort of on the back side of the brain, but not the very back. And it's very interesting. So we think it's because we're activating a circuit that is affecting the ability to do these alternating movements that is affecting swimming. So it's very interesting. Now we do have patients who actually swim better on stimulation, so it makes it even more interesting. So I think understanding the connections, which we call connectomics, that study, and also remembering the rule in Parkinson, which is whether you have DBS or not. And I did a number of interviews after this New York Times thing came out. Whether you have DBS or not, we don't recommend with Parkinson that you swim without somebody there with you, because you can turn off and you can drown. And we've had, a few patients drown with Parkinson, and it's very tragic. Some people who are even good swimmers. So don't swim by yourself, no matter if you have DBS or not.
Somebody wants to know, if you use blood thinners for DVT, is it still possible to get DBS?
It's still possible. Again, it's a risk-benefit ratio. A lot of times it's a discussion with the cardiologist and a discussion with the docs to try to understand all your comorbidities, so your other illnesses. What's the risk-benefit ratio if we take you off of the blood thinners, which you'd have to be off of them to have the operation? Will you have a stroke, or will something bad happen to you by being off of the blood thinners for the amount of time, or do you need to come in the hospital and go on a IV drip called heparin and stay in the hospital a week or two while you're being operated, and then turn that heparin off, let it wash out, do the operation real quick, turn you back on, and then work to get you reoptimized? It's tricky now, and there are newer blood thinners that are harder to reverse, and so it's a tricky situation. And what we do fundamentally is we start with a discussion with usually the cardiologist or the internist about the risks and benefits of stopping the medicine. So if it wasn't very risky to stop the medicine for a short period of time to do the operation, and then you could restart it after the operation, that would be an optimal situation. And that happens sometimes, but a lot of times it's more complicated, and it really becomes a discussion of how to manage, and it won't be an in and out of the hospital type of situation. And sometimes the risk is just too high. And so it really depends on that interdisciplinary discussion.
I think we're getting, really close to the end of discussion. I just wanted to ask one question, because a number of people asked it, is, how likely is insurance to approve DBS? So
in the United States, if you have Medicare, that's good. And Medicare plus a supplemental insurance, that's the best. If you're deemed a good candidate by a multidisciplinary evaluation, then most of the costs of DBS are picked up in the United States. If you have only Medicaid, it becomes trickier, believe it or not, and you may need to get the device donated or work with the company to get a device and work with the hospitals, because believe it or not, it's not completely covered, if you can believe that. And people without insurance, it's not covered here. Now, in other countries, it's rationed. DBS is rationed. And so a lot of times you'll see only people below the age of 70 that get DBS. So you'll see very different results of different studies, even with cognition and other features, and very different study populations. So the populations tend to be younger in Europe and in Germany and in France than they do in the United States. So in the US, we don't have a hard age limit. We do our age limits based on the screening and the individual risk for an individual patient. But if you lose insurance, you don't have insurance. It's not a state-run healthcare system like it is in many European countries. So it's not a guarantee, and it is an expensive operation.
And maybe last question, Dr. Oaken, is, you and I as movement disorder specialists are trained to identify a patient, right? When we think, technically I tell people that I start looking at a patient almost a year or two before they actually get implanted, because the first time that they start to develop dyskinesia or some kind of a motor fluctuation while I'm using, oral medications, they're on my DBS list to talk to them about it at some point. And I may even tell them, but essentially, like, the general neurologists or the community neurologists who manage community physicians, like, who manage Parkinson's, sometimes we miss that window of opportunity because the patients are not referred to us in time. What things are you doing in your community to correct that?
So, I mean, we try to get the word out. And so we try to publish a lot of books. We work with the foundations. We work with all the foundations. Parkinson's Foundation in particular is a patient organization, but also Michael J. Fox Foundation, American Parkinson Disease, Parkinson Alliance, Parkinson UK. I mean, there's tons of places. So I think getting the word out and educating is the most important thing, but also, promoting education among general physicians and neurologists. And a lot of countries, a lot of places, there aren't even neurologists, much less movement neurologists. So I think, a lot of it has to do with education. So, I think those are the things that we try to focus on, getting out and doing as much education, talk to as many people as we can, and, really creating that grassroots awareness.
Absolutely. And I want to say, do you have any famous last words, things we haven't asked you, things that you think people really need to know about DBS?
Yeah, so, I think that the field is changing rapidly. Our lab has done a lot of work with a lot of brain signals over the years, and which brain signals correlate to different symptoms. And so we're going to see a lot of interesting ways that we can monitor devices. We're going to see home programming of devices. We're going to see, situations where we are going to be able to offer better care and get to more people in their homes. And so Chris Butson and I have a big federal grant working on helping nurses and helping to get out to people's homes. And we need to improve the access, and our access is really terrible for diverse populations. And we've got to make sure everybody gets access to these devices, and that as we make them more complicated, that we help people to be able to manage them so we can really bring the care home. But I'm very optimistic. I think it's been such a pleasure to be part of this sort of, revolution in devices, and so still amazing and, awestruck to see the changes that can happen after these types of operations.
Absolutely.
Thank you for having me, by the way. I really appreciate being with your group, the SkyPass Foundation, tonight.
No, I think our community is very grateful, and thanks again. And don't go away. We're gonna not right now, but we're gonna reach out to you for more sessions in the future. And I'll turn it over to. Thanks everybody for being here. I'm gonna turn it over to Shelley for closing remarks.
Thank you, Dr. Oaken. Echo
My
all of
pleasure.
those sentiments. Absolutely appreciate you taking the time to be with us and sharing this important information. Thank you, Dr. Chitnis, for moderating. Thank you all for joining. I know we had a ton of questions. We weren't able to get to every single one of them. We will try to answer the ones that we didn't get to via email over the next 24 to 48 hours, so be on the lookout for that. If you are on this call and not receiving notifications from SkyPass Foundation regarding other virtual events similar to this one that we're doing, please send us an email at info@skypassfoundation.org. I'll put that right now in the chat. And we'll be sure to include you on our mailing list so that we can send you guys some more valuable information on events and resources that we have. That's all for tonight. Thank you again, Drs. Oaken and Chitnis. Thanks everyone for joining.
Pleasure.
Have a great night. Bye-bye.
Pleasure. Have a great night. Bye-bye.